And in young children, that can happen in the small bones. And sometimes it can actually be visible inflammation. But as our bodies age, the sickling only happens in the longer, deep bones where that can't be visible. And it ends up being, as I'm probably the least well qualified to tell you, as our many patients have told us so poignantly earlier this morning, it ends up leading to this deep, intense, invisible pain that sometimes is misunderstood and can be undertreated. And this is a series of 3 pieces of artwork. And I was devastated to hear last week that this artist who created these really incredible works of art to reflect the pain that he had been experiencing throughout his life with sickle cell, he passed away, and that's Mr. Hertz Nazaire, passed away last week of complications of sickle cell. So, you know, on that very sad note, we think about how can we create hope for the future, hope for people living with sickle cell so that they don't need to be experiencing more pain than what their body is already subjecting them to. So I should say, I had the great pleasure, along with Dr. Isaac Odami, of co-chairing the expert panel
has to put out the,
that was involved in crafting this handbook. We just got somebody who a mute issue there. Perfect. So this, in fact, I won't go into it, but very interesting. It started out where it was meant to be a quality-based procedure. So it was going to be pay for performance. So where hospitals would be given these guidelines and then would be expected to implement them, and then that would be measured and their pay would come from that. Over the course of time after we created the document, priorities changed and the decision came to this being more limited to the clinical handbook. The scope of the content was exactly the same, but the implications for the organizations changed. Just again, something to point out. So this was published at the end of the whole process in December 2017. These names are very small, but just to highlight, we had, I believe, 25 experts from across the province, including hematologists, pediatric and adult, pain specialists, social work, nursing, and it was all overseen by the Provincial Council for Maternal and Child Health. The document is very long. It's about 60 pages, and peppered through the the dry scientific language and statistics are these blue boxes, which share some really deep and meaningful feedback that was provided during a focus group in July of 2015. I'm not going to go through the details, partly because we don't have a lot of time, and also because there just are so many of them, but just in terms of giving you an idea of what's included here. We partnered with the Ministry of Health to pull specific data about rates of emergency department visits broken down by different demographics, so age, sex, location of where the patients were coming. And we use those data to help us to decide what were going to be some of our key recommendations. So this is just an example of some of the background that was provided about, for example, the C-test, which is the scoring of triage. And one of the things that you've probably already been hearing today, and one of our focus is when a patient presents, how they get triage. So what severity their visit gets assigned can potentially affect the whole trajectory of their care. Because if they're prioritized, if they're triaged at a low priority, then the speed with which the care they're receiving is going to be slower versus a C-task 2, which is the recommendation, where that's considered emergent and they're expected to be assessed quickly. And that number is what tells the physicians who they need to see first and who to prioritize.
Can I just interject for a second about triage? It's Mary. I'm the educator for the emergency department.
Yeah.
And actually, I just recently spoke to the provincial guidelines, and they're putting that in as recommendations. So they are looking at putting, because it's an anemia type of illness, that they're going to increase the severity, and it'll be reflected shortly in the triage guidelines.
Oh, that's great. Thank you so much for that.
No problem. Sorry to interrupt.
Okay.
Thank you.
Yeah, no problem. Okay. So one of the other things that we were able to do with these data was to determine where were patients, across the province. Were there certain areas where there were many more patients and certain areas where there were fewer? And mostly the numbers mapped onto what we would have expected based on population and diversity of those populations. But what we did see was that all areas of the province had patients who were affected and who were needing this care. And what was interesting was that some areas that have a lot of need and demand didn't necessarily have the focused services that patients would really benefit from. So while we were tasked with coming up with recommendations about how care could best be delivered for that pain presentation, the emergency department, we really did spend a lot of time thinking about, is that treatment in the emergency department in essence, that's kind of a Band-Aid. That's a quick fix, and we want to provide very compassionate expert care, but how could we do even better by optimizing patients' health to keep them out of the emergency department? So one of the things that we thought a lot about was how could we design care across the province to do even better. So this is very tiny. You can't read the words, but this is a bird's eye view of the flow diagram and some of the decision points at which teams in the emergency department are being nudged to determine what's going to be the best care for patients at each step. I'm going to go into this a tiny bit, just again, by way of example. So when we came right down to it, the recommendations were based on three main sources of existing clinical practice guidelines. There was the Canadian Consensus Statement, which is our national guidelines, the NICE guidelines, which are from the United Kingdom, and the NHLBI guidelines from based in the United States. And so as you'll see, and as I mentioned, and as Mary mentioned, this recommendation about assigning the CTAS level 2 was one. And then as well, in conjunction with that, the idea that, which is in some places feels like an aspirational goal, but this is all the guidelines are in agreement, a goal of receiving the first dose of parenteral, so IV analgesia. In most cases, that's opioids within 30 minutes of triage. And then some guidance, for example, for the nurses. What are some key questions to ask? How do we involve patients in that assessment and making sure that we've really heard them and understood what they're experiencing? And so while I've only showed you a very small snippet of the recommendations, they really focused around what you were seeing in this illustration, trying to intercept this cycle of barriers to care, ensuring that the clinician and the patient both have the knowledge, trying to destigmatize sickle cell, trying to destigmatize this idea of the opioid drug seeking. And while we didn't get into it in a great deal in this report, it was acknowledged of the work that we all need to do in our institutions and in our healthcare spaces on racism in healthcare. There was also a set of recommendations about what steps need to be taken for implementation, and highlighting a few down at the bottom here, including clinician education about the pain assessments, again, the CTAS, and then extensive education on best practices for nurses and doctors who work in hospitals with high volumes of ED visits of people in acute pain from sickle cell vaso-occlusive crisis will be required. So again, kind of whirlwind tour of this because we've got limited time and I want to leave a couple of minutes for discussion or questions at the end. But really, what are we trying to do here is we want to break the cycle. We want to bring in education and system improvement. And this work has been ongoing for a long time. Partners like SCAGO have been instrumental. Events like today are just so important to bring us all together so that we can together figure out ways to improve the patient and family experience, improve healthcare and provider and hospital education. And as well, we're thinking now on provincial, national, and international levels. I think today's event is really special and unique in many ways, but sets the standard for how a lot of the system improvement can happen. And it really involves our health systems working very closely with informed, activated patients, where everybody's working together as a team. There's not this hierarchy where you know, the healthcare system kind of just makes the decisions in a vacuum. We really and truly need to know what our patients, their families, and their supporters need. So I'm not going to go through this, except to say there are a lot of ways that we can think about implementing these changes, and a lot of the fruits of this implementation we're seeing in our presentations from the individual hospitals today. I'll just draw our attention again. There is a set of national consensus statement, which serves as clinical practice recommendations on not just sickle cell vaso-occlusive crisis, but on all aspects of sickle cell care. And I've shown this image before. I think for me, it really sums up what the experience of living with sickle cell and trying to obtain good care can feel like for folks, where the health issues can sometimes feel like an enormous boulder. And because of the barriers to care, it can feel like not only are you pushing this enormous boulder, but it feels uphill. So I think we all need to continue to help, as I say, many hands make light work. We can't take away the personal suffering that someone with sickle cell is experiencing, but in many ways we can work to help both prevent and treat compassionately when it does happen. So with that, I'll wrap up, and over to you, Dr. Brian.
Thank you so much, Dr. Verhofstadt. An excellent whirlwind tour of the clinical handbook. A fantastic timing, because it came up so often in the discussions this morning. So I hope that was a very helpful review for everybody who's listening in today. Please do put your questions in the chat or in the Q&A box. Now, I wanted to again thank everybody who is attending today. We have such a special opportunity here to be speaking with patients, with family members, with friends, with community advocates, with healthcare providers all together, and a chance for us to really collaborate. I wanted to recognize as well that we have Mr. Delaney Hines, who's joining us this afternoon from Ontario Health. So I wanted to say a special thank you for joining us in this conversation. Madeline, we did have a question in the Q&A about the clinical handbook, and the question, it comes from Linda Waterhouse, and it's, is this to be both for pediatrics and for adult services?
Yeah, and thanks, Linda. And Linda, shout out to Linda. She's the social worker who works with us at our McMaster Hemoglobinopathy clinic. So Linda, indeed, the handbook was meant to cover the whole lifespan. And really, because the standards of care, the expected best practices, really shouldn't change based on somebody's age. The pain and the complications can have some unique features across the lifespan, or the complications that can come on top of the pain crises. But in terms of the best practices for timing and associated investigations, and as well the need for very patient-centered intensive treatment of the pain, those things are all universal.
All right, thank you so much. And again, anyone has any questions, please put them in the chat or in the Q&A. If there's not time to address them right now, we will be having a larger Q&A after our next hospital session. And Madeline, if I could ask one last question before we do move on to the next session. Often in medicine, the question is what's next? And so with the clinical handbook, are there plans for how to keep this updated over time? Or what are the next steps in terms of guidelines for Ontario?
Yeah, that's an amazing question, Jennifer. And I would say when the handbook was developed and launched, Initially there was a little bit of, kind of uncertainty and confusion when the focus shifted from, as I had referred to, the quality-based procedure versus the clinical handbook. And it seemed initially as though there was a lot of energy and thought and planning into how to launch this information, how to spread it, and to share it. Overall, and there has been fairly good uptake, although it's been over the past, almost 4 years now. I think it has reached many corners of our province. To date, I'm not aware of any specific plan to update it or anything more that is on a schedule that's going to be happening. I know there has been a lot of focus from SCAGO and other patient organizations, including the Sickle Cell Association of Ontario, trying to look at that, trying to advocate within the government about, how do we make this, maximize the impact. And then I think your thought is really bang on. A lot of these things are going to be timeless, the principles of compassionate care, but how do we make sure that the content remains up to date, and that as the science evolves, how do we keep this document like a living document? And so those are important things for all of us to think about. And I'm looking right back at you, Dr. Brian. I think we need to be partnering with our emergency department champions across the province to look at how we can do that best.
Fantastic. Thank you so much. And I also love the expression, many hands make light work. And that is exactly what we're doing here today, right? Is to try to all come together with this shared goal. Thank you so much. So at this point, I'm going to hand things back over to you and to Dr. Ayurinde for our session with our next group of hospitals this afternoon. So thank you both very much for moderating this session, and I'm going to be listening and taking notes as we go.
Excellent. Thank you. Thank you so much. So I will have the pleasure of introducing our first group of speakers. And this will be a team that is near and dear to my heart, which is our team from the emergency department at St. Joseph's Healthcare Hamilton. So we have with us today 2 physicians. Those are Dr. Ian Buchanan, who is an emergency department physician, as well as Dr. Sarah Alavian, who's an emergency department resident physician. And joining them today is Ms. Mary Hastings, who is our nurse educator in the emergency department. And Mary has been working on this work on and off with me for several years, and we've had things, I would say, rejuvenated in the past year or so. So we're really delighted to have you all available and joining us and sharing with the sickle cell community the work you've been doing. Over to you.
Great, thanks, Madeline. I'm going to try to share my screen because I have the slides. Okay, and then see if this worked. So you guys should be seeing a slide that says improving sickle cell care. Is that right? Yes. Okay. Awesome. Great. Yeah. So I'll take us through some of the slides and then ask Ian and Mary and maybe even Madeline sometimes just to pitch in about a few things and kind of flesh out what we're talking about. But thank you so much for having us. So we are a group from the St. Joseph's Healthcare in Hamilton Hospital, and we're going to be talking about what have been some of the changes we've been undertaking at St. Joe's to think about improving healthcare for patients with sickle cell disease in the emergency department specifically. So we've kind of already had our little introductions, but our group does consist of myself, Madeline, Mary, and Ian, and we all play different roles in the emergency department, both as physicians and consultants, as well as a nursing educator. And St. Joe's in Hamilton, for those who don't know it or aren't too familiar, it's basically the informal regional site for adult acute sickle cell care. The reason being because for adult sickle cell care, the largest number of benign hematologists are based out of that center. And it kind of becomes like the informal touchstone for sickle cell patients who are experiencing an acute crisis to go to St. Joe's because they know that they have a provider there and should have some more familiarity with their presentation and their care plan. However, we do have 2 other adult emergency departments in the region, which is the Hamilton General Hospital, as well as the Juravinsky Hospital, and they do see their own fair share of sickle cell care patients as well. But we're going to be focusing mostly on St. Joe's because these are 2 different healthcare networks. In thinking about St. Joe's and what we're hoping to do with patients who are who have sickle cell is thinking about how do we become a center of excellence for care for these patients. And included in that have been some collective goals that we've come together, which includes timely and effective pain control for those who are experiencing a pain crisis, evidence-based medical management, which we'll get into, and in particular, thinking about how do we make sure that there's consistently compassionate care that's free from negative attitudes and stigma, which Madeline had already touched on earlier, as being one of the greater barriers to accessing care, which patients face. And so kind of putting all of those pieces together in the puzzle is something we're trying to achieve at Joe's to really take the care to the next level and become a place that sickle cell patients can come to and feel confident that they'll receive excellent care. So the way that this came about is truly through like multidisciplinary collaboration. So there was a core working group that identified the need to improve sickle cell care, and that came about through individual experiences where patients had presented to the emergency department and received what we thought was potentially not the best care that they could have received. And through the grapevine kind of came together as individuals who were all consistently thinking about this in the context of the emergency department, and then pulling together our efforts into one kind of unified front. So that includes the emergency medicine staff, so physicians and myself, hematology consultants, which is how Madeline became involved, and then thinking as well as about who are our colleagues in the emergency department that play a key role in patient care, and that's obviously our nursing staff, and that's how Mary became involved. So one of the first steps that we took was developing an order set, and an order set meaning kind of standardized patient orders that are implemented for people presenting with a particular sickness or presentation. So for sickle cell, that means, you know, what are some standardized orders that we can provide for patients to ensure that everybody receives a same quality of care. It makes it easier for physicians to kind of go towards the order set, and so they don't have to think through multiple nuanced things. And as well, it's easier for patients because they know they're going to receive a standardized number of things for, you know, their pain control, for their comfort, and for their investigations. So to develop the order set, what we did was review expert management guidelines, and that includes guidelines from the US as well as our Canadian guidelines. We looked at draft order sets from other hospitals, so we're very thankful for the shared collaboration between hospitals in Ontario who are hoping to do this work. And we went over our draft order set multiple times with our hematology staff, who was Madeline, as well as our nursing staff, to ensure that this was feasible to implement the order set, that it was reasonable to do in our setting, and that it actually adhered to the appropriate guidelines for management. And I have inserted just a couple of screenshots from what the order set actually looks like from a physician standpoint. So this is the actual EMR. So these are some of the things that are available that physicians can just kind of check off to ensure that the patient gets those. So, you know, providing water, providing a warm blanket, and making sure that they're assessed every 30 minutes, and that their pain is assessed every hour, and that we're doing cardiac monitoring. So that's some of the very easy and straightforward ones. And then in regards to pain control, you can see there's a lot of different options that are available. And we've tried to make this as simplified as possible so that for patients who are using opioids, there's opioids available to them, the different kinds, and then some backup plans as well. I don't know if at this point, if either Mary or Ian wanted to say anything about the order set process.
Sure, happy to chime in for a sec. So a couple of things. So we're in an Epic-based electronic medical record environment, which has actually been very helpful in terms of putting together order sets such as this. One thing that's always difficult in terms of managing culture and practice change amongst emergency physicians is that like all barriers to use need to be removed. Because emergency physicians are pretty set in our ways and pretty stubborn and always seeking the path of most efficiency. So there have been some adjustments that have been made with feedback coming from our physicians group, even within the first sort of weeks to month of use. That's allowed us to streamline the order set and hopefully improve uptake and use across the physician group. The other thing that's particular to St. Joe's that I don't think is addressed in the other slides is we have, for most of the day, a physician-assisted triage process. So what I mean by that is, patients come to the emergency department and are registered, but we have an initial assessment physician, it's called, that performs an initial patient assessment, inputs some initial diagnostic and therapeutic orders. And so we're really well positioned to identify patients that are coming with sickle cell disease and complications thereof early in their care arc to get their orders in and have them placed in a location in the emergency department where we can actually begin to act on those orders quickly.
Great, thanks, Ian. Yeah, those are both great points to point out for the particular characteristics of Joe's. In addition to the order set itself, patients who present to the St. Joe's Emergency Department, if they are followed by a hematologist and have a specific patient care plan, then they will have something in their chart, which is called the patient care coordination note. And you can see an example of this just along the side here. And that is something that very neatly summarizes their history of sickle cell, what they take for their medications. And you can see our recommended dosing regimens for people who are having an acute pain crisis. And so that is highlighted in their chart when a person presents to the emergency department. And we're trying to come up with a easy, streamlined way to proactively incorporate that into their emergency department chart, so that if somebody does present who already has a patient care plan, the physician can quickly see that the care plan is there, open it, take a look at the notes, and then act appropriately to manage their care within a timely manner. Part of our process has included feedback from patient and advocacy groups. So we've distributed the order set to a couple of patients who have said that they were willing to take a look at it and provide some feedback, and also provide some feedback as to how their care has been in the emergency department, what were things that they hoped that providers would know, and what were some of the pitfalls or strengths of their care in emergency departments, and just to help tailor, what exactly we're trying to do. We also thankfully managed to talk to somebody on the Patient Advisory and Advocacy Council board for SCAGO, and they similarly gave us some feedback about common issues that they run into in the emergency department. What do patients in this population often face, and what are we hoping to see in the emergency department? And this is a quote from someone. who gave us patient feedback and said, you know, when the crisis is at its worst, getting the pain under control while in the emergency department becomes a scary situation. And this feedback has truly been critical in terms of shaping what are the priorities that we're trying to achieve in the emergency department at St. Joe's. And it also informs the education that is ongoing, and I'll be talking about in a second. So once we had kind of put together the order set, we also wanted to do presentations to the EM staff as well as the nursing staff about obviously this new order set and familiarize themselves with it and how to use it, but also to do just a quick rerun through about what is sickle cell, what kind of patients would we be seeing in the emergency department, and in particular about what are the patients facing and what would they like to know from us as care providers. So incorporating that feedback into the presentations and the education was extremely helpful. And so I personally did the presentations on, you know, the order set and what is sickle cell. And then we also had nursing education from Mary as well on particular nuances of sickle cell care as well. And Mary, do you mind chatting about that a little bit?
I just had to unmute myself. So I've been working with Madeline probably for about 10 years now with sickle cell. We've come a long way with providing education. I think the biggest challenge is to and I'm sure maybe some of the patients have, is IV access, because sometimes their lines can be difficult. Sorry. So it's important that we have some education available. Sorry, I'm just 1 second.
No problem.
Alrighty, I'm good.
You got it.
Don't know how to do the Heimlich. That's good. So with that, we do have a special box that's available for implanted ports. The guidelines, the step-by-step processes there to access the IVs. There's guidelines that are there and available for support for staff during those off hours as well. There's been some discussion with Triage. The guidelines currently don't include sickle cell specifically, but I do sit with the provincial and a recommendation to the national guidelines that this needs to be addressed further and needs to be put in as a scenario. So they're adding a couple more modifiers to it and adding anemia as a CDIS or presenting complaint list they've mentioned. And they will be building an education example that'll be included in all triage. So any emergency department in the province and in the country, this will be addressed as for sickle cell as well, which is a positive move. I'm not sure where that will be. And it'll also be reflected when we do our electronic triaging with this as a presenting complaint, that this can be a modifier to ensure that we correctly triage that patient as a higher acuity so that they can be seen sooner than later.
Wonderful. Thanks, Mary.
Thanks.
Yeah, and as a last point, oopsie, how do I go back? There we go. As a last point, we're also developing some open access education in collaboration with other folks and hematology fellows that can be used for particularly learners. So not just thinking about addressing or kind of targeting those that are already practicing staff, but also those who will be practicing emergency medicine staff as well. So the residents and medical students, so that there's kind of an ongoing process and like a reiterative process of thinking about sickle cell care in the emergency department and what those guidelines are and ensuring people are getting like evidence-based management. And then the last thing is some of the next steps with this ongoing project is thinking about quality improvement and actually making sure that the things that we've done are making a difference and it's not just a make work project. So that includes quality improvement monitoring and data collection. So Dr. Buchanan, so Ian is going to be collecting data with another one of our EM staff, and some other input from other folks as well on different quality of care indicators in the emergency department. So some of the things that we'll be looking at is something like time to analgesia. So that's looking at the time from someone presents to the emergency department as triage, so to when they get their first dose of analgesia. Looking at their pain scores during their stay, as well as how long people stay in the emergency department. And looking at these indicators tells us, has there been an impact in introducing an order set and doing all of this education and these ongoing interventions to actually like what matters to the patient, which is getting appropriate management of their pain. And we're hoping to have a further like patient feedback and engagement and think about incorporating those voices more into these projects. I don't know if there's anything else to say about kind of the QI stuff. And if not, then I think that's the end of the presentation. Hopefully that all made sense. And obviously we're so happy to take any questions and talk a little bit more about what we've been doing.
Thank you so much to the whole team for your presentation and for all of your work that this short summary just kind of starts to scratch the surface of. I'm hoping that the three of you can stick around. The way we've got the session structured, and there's all kinds of excellent questions that are popping up already in the chat and the Q&A. The way we've got things structured is from 2:05 to 2:45 to do a Q&A with yourselves and the other two sets of presenters, if that's okay. So if that works, I'll pass it over to Dr. Ayan Rinde to introduce our other speakers.
Well, thank you very much. And it's a pleasure to be here to co-moderate. I'm a psychiatrist, but one thing I've learned about the human body is blood goes everywhere, and also the mind and mental wellness affects how we perceive so many things. So I think I've earned my role here. The next speaker is from Humber River Hospital, Toronto, and that's Dr. Marco Erak. He's an ER physician, and from all indication, he's been really busy. I sneak watched some of your YouTube bits from ER. So Dr. Erak, thank you.
Thank you. Let me just share my screen. You can hear me okay? Okay, perfect. Give me 1 second. So, oh, that's not what I wanted. Let's go from the top. So it's a pleasure to be here and quite an honor to be invited as part of this group. As mentioned, I'm an ER physician here at Humber River Hospital. I've actually only worked at the new site of Humber River. Historically, Humber River was 2 regional sites, which amalgamated into the one site, which is now at Wilson and Jane, and services the northwest of Toronto. We're a fairly large community hospital. We sort of compete with Brampton Civic as the busiest single-site emergency room in the province. And given our size and the volume of patients we see, and also given our geographic area in Toronto, we actually have quite a few patients with sickle cell that come through in crises. And we're quite embedded in the community. And in fact, it's not uncommon for our patients to have care plans with either SickKids or with UHN. However, they would come to us in crisis. So probably where we specialize the most is managing crisis and then through the emergency department. So today I'll look at some of the changes and initiatives that have occurred in the ER. For us, we've been leveraging technology ever since our new move to the new site. So EMR and order sets have been a cornerstone of improving our care for our patients. We also, as a community hospital, we treat both pediatric and adult patients. And there have been initiatives from the nursing education point of view, our CPLs, in improving care both for the pediatric population as well as the adult population. So the overview is, I'll talk about that. I'll talk about the education that has occurred that's specific to sickle cell. both intrinsic and extrinsic. And actually, the Sickle Cell Awareness Group of Ontario has become more involved with us, or we've become more involved with you over the last year, and that has actually helped change attitudes and comfort with more aggressive treatment, and I shouldn't say aggressive, I'd probably say more appropriate treatment of sickle cell at first presentation. And that's what leads into this Analgesia Comfort. So it's the comfort of using higher doses and more frequent doses of analgesia. This has been an initiative over the last year that's emerged specific for us. Order sets, I'll give you an overview of order sets. Like many other hospitals that you've heard here, we've leveraged the benefit of order sets to provide timely care and evidence-based care to our patients. And we also use patient feedback as part of our delivery model. I'll talk about one of our patient feedback groups that meets monthly with the emergency department. And finally, I'll just summarize with the technology. So in terms of what we do in the ER, we see quite a few sickle cell patients. It's not uncommon. I mean, every week it's not uncommon to have several patients come through. You know, from personal experiences, within the last week, I had a 4-year-old that arrived. What's changed is a lot of these patients are ambulatory. However, what we've done is, and CTAS is like it's been spoken, is a way of triaging these patients. However, the CTAS doesn't always encompass the urgency with which a patient needs to be seen. So for us, the ED management of these patients, regardless of their CTAS, occurs in our monitored area. So they get up triaged from the ambulatory area to the monitor area. We have admission for both adults and pediatrics. When the care required, especially for the pediatrics, when it's required beyond just analgesia and monitoring, that these patients are often transferred down to the hospital for sick children. So the biggest initiative that's been going on is identifying the patients in pain and placing them in the monitor setting. And oftentimes a physician who's in the setting will be made aware of the patient. So this 4-year-old that was managed last week, you know, unfortunately, the target of 30 minutes isn't made, but in the context of 4 or 5 hour waits that we're seeing now, this child time to analgesia was about an hour and a half because of the awareness of moving them to the monitored area and identifying notifying the physician. Analgesia now has become a priority, and I'll talk more about it. Intranasal fentanyl and other modalities are helping provide analgesia quicker and faster while IV access is being achieved. And then the actual workup is specific with some adult patients, depending on how they're presenting. If they're non-toxic, if it's just analgesia they need, then we're not doing the extensive workups that aren't evidence-based. But the workup is based on the presentation. And for the most part, there's a very low threshold to admit to patients, and specifically for the pediatric patients. Whereas if you go back 5-7 years, there was more of a push to discharge patients as soon as pain is controlled. However, now with pediatric patients, there's much lower threshold to admit and monitor and continue with analgesia. Education has also taken a transformation. Again, there's a physician side to the education, there's a nursing side, there's also the ER side, and there's the inpatient side, both from the pediatric and the adult side. I'm specifically talking about the ER specific education here. Physician rounds are regular for us. They occur monthly, and they're concurrent with the Journal Club. We've had a specific sickle cell round this year, and I think that's what started a good amount of culture change for us. Journal Club is an opportunity where, again, we've discussed, you know, the use of ketamine for analgesia, the use of intranasal fentanyl, and this has been the impetus for culture change there. And then as far as nursing education, this is mostly driven by our clinical practice leads. I've spoken to them as part of orientation and onboarding. Sickle cell is regularly mentioned, depending on, so it's regularly mentioned in the various daily huddles. So if there is a case or an outcome where someone waited longer, or there was can you hear me? Sorry. Yes. Or if there was an outcome that we were not happy with. Daily huddles are used to reinforce the use of, for example, intranasal fentanyl, the use of more timely analgesia. And the order sets, our CPLs are quite involved with creating and disseminating the education around order sets. And in fact, over the last 5 years since we've moved to computer order entry, the order sets have played a big role in our management. So I think this is probably for a community hospital the biggest hurdle. It's comfort with giving a high dose of analgesia. One thing I can say about this is a move away from a visual analog scale or a number scale to more of a patient-centered and subjective scale is the main way to go for this. We have a culture, or the culture that's being reinforced is to ask, are you still in pain? How much, how bad is your pain? Are you still in pain? Is it improved? Do you still need analgesia, rather than focusing on the actual specific number? And we know this because a patient may have a 9 out of 10 pain, but using distraction techniques. And then there's certain biases in there that you may or may not believe the 9 out of 10. So that the value of the 9 out of 10 is not as valuable as, are you still in pain? Do you still need analgesia? So for adults, early recognition at triage has been important. And again, these patients are up triaged, usually to a monitored area where we can start IVs and give IV opiate medication. And I've talked about the subjectiveness of the pain. Our rooms are now sort of an overall ER patient experience revitalization. Our rooms have the opportunity for patients to use distraction techniques such as a computer or a TV in the rooms. And again, we're focusing on patient-guided analgesia. So the culture here is for physicians to be comfortable with giving Q30, Q1, Q2H opiates at a dose that may be atypical for a 25-year-old with limb pain. Who isn't a sickler, who doesn't have sickle cell. From the pediatric point of view, it's getting comfortable with using intranasal fentanyl, but also just getting comfortable with using opiates in general. And this is still a work in progress. Oftentimes when you prescribe opiates for pediatric patients, there's often hesitancy in giving it, and this would be regardless of the presentation. So the CPLs are working with their nurses to be comfortable with this. And again, this is why our patients are being moved to the monitored area, where the nurses tend to be more comfortable with providing opiate analgesia. The order sets, as with most hospital, has been a cornerstone for us. We have an ER sickle cell crisis order set available in the for the physicians. It's easy to use. We use Meditech as our EMR. It's been approved by pharmacy. It's a multidisciplinary committee that approves these order sets, and it provides various analgesia modalities, types, and routes. For pediatrics, we have an admission order set. The ED specific order set is still a work in progress. However, we do leverage fluid and analgesia order sets for the pediatric population, again, to assist with the treatment of the pediatric patient. The patient feedback, there is an avenue for patients to provide feedback. We actually have a Reinventing patient care council that meets regularly on a monthly basis. And this group and committee reaches out to patients through callbacks and surveys. And this is a venue for patients to advocate for improvements of patient care. And this group actually helps to foster change in regular ED care. The callback process is usually after an ER visit. Patients are reached out to, or family members are reached out to provide their feedback in terms of the timeliness of their care and the overall experience of their care. Finally, where we see our strength is leveraging the technology we have. So our EMR, like I said, our ER pediatric order set is to come. However, we have the ability to, like any EMR, pull data for quality improvement projects in terms of analgesia, time to admission, return visits within 30 days. To date, there are no such projects that have occurred, but I think moving forward, this will be an important area of consideration to modify and continue to upkeep our care. Finally, the command center is an area where we have the ability to flag various patients. We do this for sepsis patients. So when they arrive, to flag the charge nurse and the department as a whole of the patients, and to ensure that we meet care outcomes. So this is an area of opportunity, again, for sickle cell patients to meet the the timely outcomes, or sorry, to meet the required time to treatment and triage. So again, as a community hospital, the big three areas of or goals for us are culture change. So understanding the analgesia requirements and understanding the need for early and appropriate analgesia, and then having that lead to changes in practice. So I think once culture changes, practice changes, and there's no easy way around this. So I think ongoing education, ongoing collaboration is required. What the other hospitals are doing around us provides a pathway for this, and with the ultimate goal of improving the outcomes for the numerous patients we receive regularly. So thank you very much.
Thank you so much, Dr. Rack. And what we've heard is how hospitals are leveraging algorithms, pathways, technology, and that takes us to the next presentation before we take questions, but this is getting really exciting. Now, the next presentation is from a group from Children's Hospital of Eastern Ontario in Ottawa, and it's a dream team with Dr. Robert Clarkson, pediatric hematologist and oncologist, program leader of the hematology program. We also have Camilla Leger, social worker with the hematology team, Christine Chrétien, case manager, Hemoglobinopathy program, and Alexander Wong, clinical pharmacist, hematology department. Over to you, Ottawa.
Yeah, well, thanks for that very kind introduction as the dream team. We'll have to try to live up to that. This is very exciting. So this is going to be quite a different slant than what you've been hearing with this session. I'm just going to share. Yeah, here we go. Share screen, and there we go. Oops. Can everyone see the slides? Perfect. Great. So again, we're a pediatric hospital, so it's going to be a little bit different than the previous presenters. And I think the key thing we want to talk about is how we're a team that works together, and you can see all the members of our sickle cell team at CHIO. And I think what we're going to start off with is just talk about what all of our roles are and how we kind of work together to. So quite frankly, my job is to try to keep all of our patients out of the hospital, out of the emergency department. I almost feel that if they go to the emergency department, it's a failure on our part. So we're working very hard to try to, put the focus hopefully on preventing problems. So, I'm part of the physician team. Dr. Simpson is the other leader, and she's really the one who's driving things for sickle cell patients. And so we have an attending staff. We have we now have a physician assistant to help us with clinic, which is a big help. We have fellows, residents, and medical students coming through. So it's a fairly big team. And the physician part of it, and with the learners, is to try to identify problems by families and patients, and asking questions, examining, and then going through the test results. And if we find things that are relevant, making sure that families are well educated, because I think that's really crucial. Review medications together with our pharmacist, and I'll let Alex talk about that in more detail, and make adjustments to treatment, and try to encourage families and patients with the importance of taking their medication, because it's tough when you have a lifelong disease, and being on medication for pretty much for life. It can be challenging. And then we arrange for appropriate testing and follow-up. So that's kind of where the physician piece of it goes. And I'll hand it over to the real star of the show, which is Christine.
Thanks. So I am the nurse case manager, and the families have my phone number, they email me, and now with Epic, they do also have my chart, so they can very easily get a hold of me pretty much any time during working days. And so, and then if something happens in the evenings or on the weekends, they do know how to get hold of the physician on call, because we do really try and keep our patients out of the emerge. That is one of our key goals. And I agree with Dr. Clausen. If they go to emerge, they have to have had a fever, or, you know, we really don't want them to be in the emergency department. So it's one of our key goals with them. We also, you know, different families have different needs, and we do try to continue to give them what they need and to try and manage, you know, what they're able to do, what they're not, and how we can get them the resources. Education is also key to the patients, to the families, and also to staff. So this is one of the things that we try, or I try to do. And yeah, and just get the other, you know, there's other teams throughout the hospital that we have to, that we need to work with. So just, we try and keep that going and keep everybody on track. And we do have a transition program that is a little bit, it's not, we're doing our best. We could do much better, of course, but I think we're doing better than we used to do. So that's one of the good things that we're doing at this point. And we also, yeah, I guess that's pretty much a little bit of snippet of what I do.
Thanks, Christine. Next, Owen, did you want to quick talk about the administrative staff?
Sure. So we are so lucky to have Melissa on our team as well. She's the admin support, and but she has helped us organize education sessions for families, for patients, for staff. She also helped in the past to do some of the sickle cell education sessions that with SCAGO, and she was on this sickle cell group advocation, and yeah, we are blessed to have her on our team, and she's amazing.
Thanks. Next, I'll hand it over to Alex, which is I just want to highlight is a very a new addition to our team, and is really a huge benefit, is that we actually have a pharmacist on our team. So Alex, maybe you can talk a little bit about what your role is.
Thanks for that, Dr. Clausen. So I'm Alex. I'm relatively new to the team, but I've learned a whole lot in the last few months. And sickle cell, we have this clinic every week, so it's probably the one where I have the most exposure and the most experience so far. So I kind of deal with some basic stuff. I make sure everyone has enough refills. So I send new prescriptions if I need to. If Dr. Simpson or Dr. Clausen wants to start hydroxyurea or folic acid or amoxicillin, that's what I do. It's not very interesting in terms of like picking the medication and stuff like that. It's quite straightforward because there's only a few medications, but I try to take that off their plate so they can focus really on the whole picture. And I can deal with pharmacies, I can deal with the insurance, because no one wants to deal with that except me. So that's the second point. The third point is, of course, very important, especially with the management of sickle cell disease. Hydroxyurea is a medication we need to take every day. And it's very difficult as well because you don't feel better. So you have to sort of drive that home. Yeah, you won't feel better, but it helps to save your life. It keeps you out of the hospital. It keeps your pain down. So I sort of rationalize and explain to patients why that is and why they need to take this medication every day. And same thing with amoxicillin, especially in those 0 to 5-year-old group. That's the age where they're most susceptible to getting infection. So we want to make sure they're on penicillin or amoxicillin And moving on to the fourth point, once we get them off amoxicillin, we want to make sure that they're fully vaccinated because they have an increased risk of getting sick from encapsulated bacteria. So we want to make sure they're fully vaccinated before we get them off antibiotic prophylaxis. And so that's involves quite a lot of planning in clinic. I'm running around everywhere and getting some vaccines organized for the patients so that they can get the vaccine during the clinic time. So they don't
and I just want to highlight that this was an area that we were very much falling behind in. We were not keeping up with the vaccines for our patients. And so Alex has been a huge, huge benefit for getting our patients vaccinated. Sorry, continue, Alex.
Yeah, and I have a sort of, it's not really an order set, but there's a standardized template that I use to make sure that everyone's getting the same sort of care and that they're not missing any vaccines. And so if they're missing any vaccines, I just give it there in clinic. Obviously, I make recommendations on if the dose can be increased. So at age 3, we change the antibiotic dosing. If they're not optimized on hydroxyurea, I'll optimize that dose. And a lot of people don't know this, but in Canada, we only have the 500 milligram hydroxyurea. And so a lot of doses involve doses higher than that or somewhere in between. So how do you measure a dose of 200 from a 500 milligram capsule that can't be split? So I show patients how to dissolve and dose. And because of that aspect, there's also teaching surrounding safe handling of hazardous medication, because it is a chemo drug traditionally. And so we want to make sure patients who don't need to be touching this aren't touching this with their bare skin. So, and we want to make sure they're disposing it correctly. And of course, I coordinate with Cami, who will be speaking right after this regarding coverage and stuff like that. Sometimes the situations can be a little bit complex. So I will coordinate a lot with her and Christine to make sure that patients get their drug on time and there's not that many delays.
Thanks, Alex. Sorry. Next, I'll hand it over to Cami.
Hi, I'm Cami. I'm the social worker with our sickle cell team. Not sure if you can hear me. Okay, good. Wonderful. So with our psychosocial team, we kind of round out our whole multidisciplinary, our holistic team, you would say. So with us, we include our social workers. So it's me for all of hematology, specifically with our sickle cell population. We also have child life specialists who are super integral in supporting us with our youth and our children, especially when it comes to understanding the hospital systems or, some of our patients, if they're they've been with us for a long time and they might have issues related to needle fear phobias or whatever the case may be. They're very integral resource for us. Then we also have our resource workers, which is a fairly new position for our hospital and specifically for our social work team, because I like to say I had a hand in that because I realized how the complexities of needs that our sickle cell families have and stuff. And I realized, we could do more if we had more support. And so with our resource workers, they're very integral in now supporting our families so that we can look for medication funding when, some of these medications are very expensive or family situations, make it that finances are strained and whatnot. And so we have more resources that we can tap into with our resource workers, which is really, really helpful. And then we also have our psychology team. It's really important the role that our psychologist plays with our team, especially over the last several years. As our team, we've been advocating more and more for our sickle cell patients to have those neuropsych assessments done, whether it's within hospital or if we can find resources within the community, or if our psychologists themselves can be able to conduct some sort of psychoed assessments to support our populations. Because once again, resources, there are some out there, but they can get very costly, and we wouldn't want our families to feel at a detriment because they need it and we know it and the research shows it. And so it's been great, and it's been a long road coming in the last several years to have more assessments done for our patients, because then we realized how much it has improved their quality of life, especially with school and whatnot, and that they're no longer falling behind or they don't feel limited by their sickle cell disease. And so that's part of the work that I do when I do my counseling with our teenagers and our youth and children, to feel like, you can live the best quality life possible, and we want to be there to support you, to fill in any of the gaps that exist or address all the barriers that exist. And so a lot of my role is I like to meet all of our new sickle cell families that join us, and obviously continue to follow up with all of our families that we've already had. And so part of my role is to really assess all the biopsychosocial needs that arise and really figure out, okay, how can we best serve your needs? And so that's part of the collaboration of connecting with our pharmacy team, connecting with our nursing staff, connecting with our doctors to say, how can we make your care that much more optimal? And so I think it's very important when families have a strong rapport with our team and that we're able to address those needs as needed. And so then part of that extra piece is how do we make sure that everyone else at CHEO is able to respond to the needs of our sickle cell families. And so that's where we do a lot of educations, and like Christine alluded to, so we do lunch and learns, we do seminars, webinars, we do events throughout our HEMONC team so that they can be more comfortable and more aware of kind of the needs that come up with our families and how do we respond within our clinic dynamic. And then also too, we kind of want to build that piece where we're working with our families and being able to provide these team night events, for example, which is one of my favorite things to organize year after year, because it's a way to actually have the youth be in a room together, get to know each other, get to learn from their experiences, and also kind of we are able to provide that educational piece, especially when we're talking about medication adherence and talking about the importance of nutrition, diet, exercise, well-being, and how do we avoid our youth from coming into hospital, and especially for me around exam time with their teenagers. How do we make sure that stress and exhaustion doesn't like trigger sickle cell crises? And so we're doing the best we can, and I know there's always room to improve.
Oh, thank you, Cami. I know we're cognizant of time, so there's obviously many other components to what we're doing at CHEO. We do have a good rapport with our ED team, and I was very interested to hear some of the things that are being used at some of the other hospitals, for instance, with communication with the ED department. We have a good relationship as well with our anesthesia team, with the acute pain management. And about 7 or 8 years ago, we established that if patients aren't responding quickly to pain management in the emergency department, we bring in the acute pain service with anesthesia and start them on patient-controlled analgesia. So that's been a big advantage, and so that's all nicely set up, and we have order sets within Epic for that. You know, Epic and MyChart has been very useful. We're getting more and more of our patients onto MyChart, which is really nice because then they can actually they have access to their own information and to their own blood results, and that, so it really empowers the patient. So that's great. I think Christine mentioned our transition clinic, which we do twice a year. At one point, we did have the physician from the adult team come to our hospital. We don't have it set up at that at now, but we do have the social work and nursing coming, so that it's less of a scary move from CHEO to, it's right next door, so it's not very far, but still we're working very hard so that we don't lose patients in that transition time. And I think so those are the main things that I wanted to cover, and here I'll stop my sharing. And I just want to, hopefully it's given you a little bit of a picture of what we've been able to accomplish at CHEO. I'm very proud of our team, and I'm very happy with what we've been able to do. So hopefully we can, I think we are fortunate within the pediatric realm that we've been able to get these resources, although I got to admit, I had to fight very hard to get these resources. They didn't just get handed. So you do have to work very hard to get access to a supportive team like we have. Thanks.
Well, thank you very much. And we've heard the presentations from the hospitals, and a few points before we move into the question and answer session. Is correct, Madeline? Yes. So of course, I'm going to throw in my bias because I'm a psychiatrist, and we know that 75% of emotional and mental disorders have their origins before the age of 25. So it's critical that we get in really, really early. We also know that where there's chronic pain, we increase the risk of mental and emotional difficulties. And alongside that, with pain, if you hurt, you hurt. All pain is real, whether it's emotional pain or physical pain. So from what we've heard, and this is a question to each of the centers, what are we doing to address the emotional and mental health of people who may be dealing with sickle cell? And of course, their families, because if someone's ill, mom and dad love their child very dearly, siblings also concerned and worried. What are we doing to support the emotional and mental health for each of the centers? Do we want to go in any particular order, or all yours?
Maybe we can put some folks on the spot. I feel like the CHIO folks already kind of told us, although they were talking maybe in the being proactive on the outpatient side. Any thoughts from our St. Joe's Emerge docs on how we can best or what's being done from a mental health standpoint in that acute mental and emotional support standpoint when somebody's coming in intense pain?
I mean, I think early recognition goes so far. Just having patients realize that you see them, that you have an understanding of what their illness is, that you have an understanding of biases that they've been exposed to in the past. Really pretty quickly you can develop rapport. And in my experience or my feeling is that, when those when you can establish that rapport and those patients feel understood quickly, it really sets them at ease, followed by, delivering on your promises of, getting those individuals into a bed and providing them with the therapy that they've come to the hospital for. I would say at St. Joe's at the present moment, there's not a great back end follow-up after discharge. We're obviously lucky to be very well supported by our hematology colleagues, and our program in the community after discharge is very strong. So I think we're reassured that patients aren't being discharged out into the ether. I think the work that we've begun also includes an ongoing measure of quality of care, which I think will be pretty instructive going forward. At St. Joe's in particular, I mean, I would say it's a great place to work. Our relationships with our consultants are excellent, and advice as well as really closing the loop on patients' follow-up is really only a phone call away. And the consultants, of all services that we deal with are very accessible and happy to hear from us, which makes a very big difference when we're trying to care for individuals that have complex needs, and just being sure that their discharge to the community is safe.
Thank you. We see a hand up. It's Janet, but that was really helpful. Thank you. Janet?
Yes. So I know I'm not, I wanted to put Camellia on the spot and Chio on the spot actually, by answering a few years ago, we, I'm not sure how it came to happen, but Camellia reached out to our family, and she asked us if we wanted to go on a trip. And it was a trip that was being sponsored by an anonymous donor, and everything was paid for. We just had to say yes. And so that's one of the ways and that trip really, we enjoyed ourselves. It was amazing. And so that's one of the ways that they do provide that emotional and, social support to families by doing things like that. So I just wanted to bring that up, and thank you.
Well, thank you so much, Janet. What we are hearing is non-clinical, non-medication interventions that can make memories of childhood and growing up treasured can go a long, long way. You don't want all your memories of childhood and mum and dad just being pain and hospital. And thank you so much for those creative non-prescription medication pain management interventions. Anything from any of the other hospitals?
Yep. So I think I mentioned this culture. I think is a big word here. I think oftentimes patients, well, not to speak for patients, but it's not uncommon for patients to really come in crisis. And if you have a culture that when they come in, not necessarily in crisis, they're going to be stigmatized, wait a long time, and not receive the appropriate pain. Why should they come until they absolutely can't stay at home? So I think creating the culture within the team goes a long way in terms of, again, this is where not necessarily focusing on the number of how bad their pain is, but trusting the patient, believing the patient, and understanding that, again, there are distraction techniques. These are patients who have lived with pain their whole life. So regardless of how they present, a fractured limb, someone may be screaming, but someone here with strong pain may not. And I think the culture pieces go in from triage until discharge. So, minimizing comments or eliminating sort of comments of, oh, he doesn't look that bad, but rather just, walking into the room and acknowledging, hi, I know you're in pain. We're going to get your pain under control, and we're going to treat your pain. And again, this is where the group, the work with this group, at least at our hospital, from our physician education day and going forward, that's been the main focus for us, is just changing the culture and acknowledging, there is pain. It's not about your own opinion of how bad the pain is. It's about the patients, and just get the pain under control. So something we try and instill in our physicians is Q15, Q30, Q1H pain management. Just get the pain under control and get it under control aggressively. And then again, for us, what helps from that point of view is the rooms we have in the subacute and acute areas are independent rooms. So the patients are independently there. They're 4 walls, so they're not listening to other patients. They have the ability to distract themselves, turn down the lights, get warm blankets. And then for mental health overall, our mental health colleagues are to be commended. Their follow-up, or the rapid access clinic, is actually quite rapid access. So within 2 weeks, a patient may be seen. So if somebody is expressing anxiety, depression, or the want for increased mental health support, we're able to refer them directly out of the ER. And the final part, I'd say, for pediatric patients, like most pediatric hospitals, as a community hospital, at least for us, we have the ability to have a child life specialist come and help with the patient. So I think that helps with the overall experience too.
Thanks so much. So what we've heard you say very clearly is the importance of validating the person's experience. It's not for us with all the letters behind our names or the power we have in those situations to invalidate or give our say. So validating the person, and thanks so much. What we also heard you describe is the importance of the milieu, the environment, that shows respect and dignity. If you're put in a pretty nice place, it shows that people care, rather than some dingy cold room behind a building. Looks like Dr. Clausen's got something to say.
Yeah, I just want, I've been doing this for a while. You might be able to tell from my gray hair. It's been 22 years, and it's quite dramatic. And hopefully, it's moving through the change in what's happening with the management of sickle cell patients with sickle cell disease over the 20 years I've been doing this. Children are. When I started, there was many children with many complications and a lot of pain. And that's fortunately in the minority now. So there are a few patients who still have pain, but the majority of patients are actually doing very well. So you're setting a good stage. So I think that's really important. And really that's happened in the last 10 to 15 years, that we've been able to be aggressively treating, and hydroxyurea is the huge game changer. So by aggressively, and I'm very aggressive about, because I know what the problems are. I've seen the pain that these kids are in. So I'm very aggressive about giving hydroxyurea to prevent the pain. So, and you set that good, if you set things up so that you avoid the pain, yes, you will occasionally have pain crises, but much less often and much less, hopefully less severe. So I think, it's really, the prevention is so key to all of this. Thanks.
Thank you so much. There's something mentioned in the chat. Pain is very important, but please don't forget the need to attend to fever, potentially life-threatening infection, need for first dose antibiotics after culture within an hour of arriving. This would apply to all ages. And so what we're reading here is really early intervention, prompt intervention, focused and evidence-based. Alex, you've got your hand up.
Yes, I just wanted to address a few questions from Janet. So Janet is asking, this is only a question for the panelists and hosts, but I thought I would share it just for everybody else. But I'm scrolling up here, but I think the gist of your question here, here we go. Aren't sickle cell patients supposed to be on long-term prophylactic antibiotics? So not in our practice. We at CHIO go based off the sickle cell consensus of Canada. And so in the sickle cell consensus, it just says to basically give prophylaxis until age 5. And to answer your other question, Janet, are there any additional vaccines required for them to have beyond the standard ones? So the answer is yes. So like I mentioned, they are more at risk of getting these infections caused by encapsulated bacteria. So strep pneumonia, Neisseria, meningitis, H influenza. I think I'm missing one, but basically there's additional vaccines on top of your routine one. So that's part of my counseling. I tell them, yes, your child needs routine vaccines at age 2 months, 4 months, 6 months, whatever, but they also need additional vaccines. So and oftentimes the family doctor isn't really aware that there's these requirements as well. So I'll coordinate with the clinic so they can do vaccines as well.
Thank you. I'm going to hand over to Dr. Vahovsek now for more questions, and keep your questions coming in. You can put them in the Q&A box and we'll try and get through them in a timely manner. Thank you.
Yeah, thank you so much. So there are a number coming in both in the chat and in the Q&A. There's one comment and question here from Perry. Where psychological help is concerned, is it just for youth and teens? Because as an adult, I have less crisis. However, I'm finding my struggle of the patterns that sickle cell has created over time affecting me even now on school and goal setting, etc. So I feel like this is really a tremendous question, and I'm really interested in perspectives from representatives from all of the locations, because I imagine there's some differences center to center and differences, whereas we're focused on the outpatient setting versus the emergency department. Maybe actually, why don't we start, again, feeling like we're putting people on the spot. Mary, what are your thoughts on access to, because, St. Joseph Healthcare Hamilton, we are a mental health hospital for our region. What perspective have you noticed in terms of access to these mental health services?
Very good question, Madeline. We actually are lucky that we do have the resources that are available in our department, because we're regional for psychiatry as well in our LIN. We do have great teams here. We have a social worker that's available on days and also on afternoons, and also in emergency psych that's available that can come and address those situations. We have something called an admission avoidance team, so they can also help and spearhead some issues that maybe not necessarily be done here, but on an outpatient basis to see what resources are required, finances are required, or whatever, and they can help and support that as well. So over the last a few years, but there's a lot more teams and supports that are available within the department, as opposed to like 10 years ago when all this kind of came about in our department. So we've got a lot of great resources, and I think it's just would be to ask the question and to say, I need some assistance, I need some help. I think we're really good about looking at patient-centered care. It's not just the diabetes or the nephrology or the mental health or whatever that's there. We look at patients on an individual basis and see, because they're really the drivers of their health care, and see what we can do to support their care. So hopefully that answered your question.
Yeah, thanks very much, Mary. And I think, hopefully increasingly we're committing resources and really being attuned into these mental health issues. And, I think you've highlighted that sometimes it's an issue of navigating, sometimes it's just an issue of speaking up. Other times it may be uncertainty about how to navigate the services. Sometimes you need a champion to be connecting those dots, recognizing that you're having that need and helping with navigating. I think that's a big piece of it. And in many ways, the model that you've got at CHIO, having the services embedded in the team, clears away all of those barriers or many of them and adds in the layer of mental health support that knows exactly the lay of the land, doesn't know exactly what an individual is experiencing in their own unique life, but knows about sickle cell disease, knows about some of these common challenges in a way that it might be exhausting as a patient to have to bring a mental health provider up to speed on some of these things, I can imagine. So I'm not sure who's best to comment from the CHIO team, but what are your thoughts on all of that?
I think it's really important because I'm so glad that we're always talking about mental health because it's a huge, big part of what we do and everything. And it's also important to talk about the stigma surrounding mental health. And so that's kind of what I've noticed in my practice is working with families and really trying to find avenues where I can get them connected to services, because it's beautiful because yes, we are a pediatric service, but it's also important to really focus family as the whole system. You can't just look at the child and their needs without addressing kind of what's going on in the whole family system and structure. And so that's part of my role is when I do my assessments with families or when I do my check-ins with family, it's never just asking the child how they're doing. I ask like every single member of the family that's in the room. And so based off of that, we're able to, streamline services according to their needs. So whether parents are saying like, I need mental health support, so I can refer them into the community, finding areas that services where it's like more feasible for them. So mental health services that have like a sliding scale option, because I don't want to just assume that everyone has insurance and everyone can afford it long term, especially when a lot of our families, when we talk about culture, it's like, how do I feel comfortable connecting with this worker if they don't understand my culture? And then more specifically, they don't understand my child with lifelong chronic conditions and whatnot. And so that's part of my role is to try to, build good partnerships in the community with stakeholders so that they're good options to refer our families to down the road when it comes up. But also, like we were saying, we also try to look at it from other perspectives. So something that we're really proud of is like every year we do Christmas baskets, holiday gift baskets. And so I've been sharing that for the last several years. And part of this is to make sure that all these extra needs, these emotional needs are met during the holiday seasons. And that's usually when we see a huge strain. And so part of that is working with the community so that we get donations so that we can support our sickle cell families when it's really tough, because a lot of the times our families don't want to ask for help, and then I'm just like, what, are you okay if I nominate you for this? I know you didn't ask for it, but are you okay with this? And getting their consent and their permission. And then just to see how that supports them, because they're like, my mental health was like plummeting because it's the holidays and my children are expecting gifts and we want to like provide as much as we can, but all year long we're living within our means. And so any little bit helps. And so I noticed the difference and the impact that helps our families with, which I think is just super, super important and special. And then just in general, I think it's just, we're privileged that we have such a great rapport, because I always worry sometimes, because I'm always cognizant of my place and my privilege and everything. And so I'm always so humbled when our families are able to connect with me and tell me, hey, Cami, I'm really struggling. Like, what should I do? Or who should I talk to? And so just to have that open communication where there isn't judgment, there isn't any concern, and families can voice their concerns, and then we figure out what's the best course of action. So we're really happy about that.
Yeah. What a fantastic resource, and really that holistic care that we've been talking about, both on the outpatient side, so in our clinics, in our teams, and then kind of zooming back into those aspects of holistic care, even in the acute setting. And I'll just, there's a couple of really important comments here in the chat. So from Rana, we need to destigmatize anxiety and depression by addressing this problem with families before they become an issue. many times people do not know that it is normal to have these feelings if you're affected by any chronic illness. It's exhausting, you know, kind of referring back to that image that I had shown earlier. It can really tend to become demoralizing on some days. And so I agree, normalizing that and having other people who have been through it, I would say too, which I know came up earlier on, but just to highlight that. And then I'll read this comment from Beverly and Duku. I think mental health really needs to start being at the forefront of health/help for sickle cell patients. It's hard to ask for help or even mention the struggle, being that you're already in a struggle. This is a great discussion. So thank you for all of that. I'm going to just quickly segue away from the mental health discussion, but I have a feeling we'll be coming back to it. I noticed earlier on in the chat, in the Q&A from Ann Bayless, a question directed to the use of ED order sets. And I think that question came through when the St. Joe's team was speaking, and Dr. Buchanan did respond to it in the Q&A, but I think it would be nice to discuss that a bit more, about both Dr. Buchanan and Dr. Arak. You know, so is this an obligatory thing, and how do you audit whether it's being used? Are there certain measures of success that you're following? And you know, maybe some reflection on whether there are any pros and cons to order sets, and reflection on, don't want to make this too big of an ask, but I want to make it open-ended so that you can go with it where you like. We'll start with Dr. Arak. Also to kind of what might be a process for reviewing the order sets, you know, assuming that they may not be perfect right out of the gate.
Thank you. So order sets are certainly not obligatory. They're meant to leverage two things. One, some loss of efficiency that happens when you go from paper to electronic is meant to you're meant to gain that back through an order set, and certainly that does help us with our efficiency. But specifically to a specific disease, the order sets are also meant to guide practice to be more evidence-based and to minimize the unnecessary testing or treatment. So, you know, a good example for us would be our bronchiolitis order set that we have, for example, which minimizes interventions and non-evidence-based treatments that you might have used 20 or 30 years ago. So in the context of sickle cell, we're leveraging the order set to provide the physician with a various various modalities of analgesia and increased frequency from what they might order normally. You know, the typical is to order Q4H, so this is pushing them towards ordering more frequently. So no, it's not obligatory. We don't, as of now, have a process of monitoring or auditing our order sets in terms of are they used, how often they're used. But certainly the order sets themselves do get revisited after several years, and it's usually driven through our nursing leadership and our nurse education leaders. I think I've encompassed everything. Anything else I missed?
No, that was great. What do you have to add there, Ian?
So similar at our institution, physicians aren't obliged to use order sets. They really just are intended to put all of the orders that you might be hunting and pecking for in different locations in one convenient place. I mean, I don't mind if physicians are or aren't using the order set that they've built, so long as the care is of high quality and evidence-based. So when we go back to audit care, we'll have a look for quality indicators that may not include every order on the order set, you know, and certainly some things are more important than others. But you know, we built the order set with the best evidence available, and so many of the things that are included in the order set will be things that we're looking for in particular. The other thing I think about order sets is that they provide a reminder to physicians about certain aspects of care that you know, may not be included in an order, or may be communicated verbally to our nursing colleagues or our respiratory therapists. Things such as, you know, ensure that there's, you know, oral fluids at the bedside, warm blankets, private room if available. things that I think are important details that sometimes aren't in keeping with the other sort of medical, quote unquote, medical orders that are placed. And so I think it helps with individual patient encounters, but if providers are looking at those order sets with some frequency, it's just some spaced repetition in terms of reminding them of what high quality care is for this specific population.
That's great. Yeah, thank you very much. I know some hospitals have had, some emergency departments have had emergency pain order sets for a long time for sickle cell. Others have come to it more recently, and there's all different variations and permutations, including different EMRs and things like that. I'll put a shout out to a national organization that exists called the Canadian Hemoglobinopathy Association. I'm a member of the board. Other folks, Rob Klassen's been involved for a long time as well, and many other of our attendees. So they do have a nursing group that keeps kind of a repository of all the various order sets from across the country. Also, as Dr. Kirby Allen had mentioned earlier, the specific, very unique needs of people presenting with fever, and making sure that we're very proactive and manage them differently than someone else who may just be walking in with a fever. So if there are any centers, any attendees today who haven't yet gotten the ball rolling on this kind of work, we're all here to help, and there are in fact groups of specialists in sickle cell, as I mentioned, CanHem, who in fact are many of us involved. I should have shout out to Christine Chrétien too, who's a member of the board for a long time. So I'm going to pass it back over to you, Dr. Rinde, and to continue on this conversation.
Great, so this is really warming up nicely, and I'm glad we start off with the mental health piece. I was wondering, many organizations providing patient direct service also have advisory boards or advisory committees and so on. And I was just wondering, for each of your hospitals, do you have people with lived experience or family members on your advisories guiding the work you do and helping with some of the representation? Thank you.
We do have patient advisors that help to inform care in the emergency department. I mean, at the moment, I don't believe that we have a patient advisor that has sickle cell disease. In particular, with the quality work that we've done recently, we've been sure to engage community members, specifically with respect to feedback about the order set that we've developed, ongoing quality of care reviews, and we'll continue to do so in the future as we ensure the quality of care is maintaining a high standard.
Thank you, Dr. Buchanan. So that was from Hamilton. Any other?
Yeah, I can just say at CHEO, we've had a long-standing patient advisory board for at the hospital. We've recently they set up a specific one for the oncology families, and using that model, we are in the process of setting one up for the hematology families, which would be in a big component. Would that be the patients with hemoglobinopathies, with families with children with sickle cell disease? It's not in fruition, it's in process. A lot of things got delayed because of COVID, but hopefully it'll come to fruition pretty soon. I don't know, Christine, have you heard anything more? Is there more action on that front?
All right, no, I was told January, but I don't know. We'll see.
Dr. Arak?
Yeah, so we, like I mentioned, we have our the Reinventing Patient Care Council, which meets monthly. So similar to St. Joseph's, we have two patient representatives, currently neither is a patient with sickle cell. But this advisory committee or this patient care council is the one that helps new initiatives in the emergency room and helps highlight any issues that patients may be experiencing. The other side, in ways we reach out to patients, would be through our regular post follow-up surveys, which again, they're not sickle cell specific, but they do look to gain feedback from our families and patients that have visited.
Great. Well, thank you very much. So a little voice says in my head, nothing about us without us. And I'm glad we're committing to that as well. The next question, it's going to slight segue, is we're in a period of all sorts of digital innovation and apps and devices and so on. Have you guys got any cool, exciting stuff, innovations in that space?
Well, I do think the My Chart is a big innovation. It's been, I mean, I would say it's a light change, but it's not. And I personally use it for my own. When I go into see the doctor, it's kind of nice that I can actually look up my own results. And I've encouraged our patients, and there's been definitely more uptake recently. So I think that is a big step, because families can look at their own, you know, a child can, for instance, they have it on their app, they have the diagnosis and everything's right there, and they can look up the latest, you know, hemoglobin if they wanted to, or I focus a lot on fetal hemoglobin levels to, you know, to encourage adherence to hydroxyurea, so they can, I have families who have little fights going on as who's got better fetal hemoglobin levels, because of the, you know, just to try to make it a bit, get them a bit more engaged. So I do think My Chart is definitely a good step in the right direction.
Excellent. Dr. Clausen has been around a while. Dr. Buchanan?
In Hamilton, we have a citywide wait time dashboard for emergency departments. So people are able to log in, and we have three emergency departments and 2 urgent cares within Hamilton. And when people are sitting at home deciding on where they prefer to go or where they're hoping to seek care, they can look to see what the wait times are at each institution. We do hope that our sickle cell patients are always coming to us at St. Joe's. For all the reasons that Dr. Lavian had outlined in her presentation. But I think it has helped with load leveling on busy days in the city for sure, and probably allows for sort of the most efficient care across all capacity here.
We also have a similar as CHIO with Epic. It's called My Dovetail, which is just a name for St. Joe's, but patients can get signed in and they can check their blood results and look at their results and stuff as well, which is really helpful. It's also integrating a lot of information that we get from other hospitals and facilities. We can have that direct electronic information, which has really been very helpful over the last 3 or 4 years once we've implemented that as well. So it's made a big game changer. Instead of waiting for medical records and trying to look things up, it's all there at your fingertips and available as a resource.
That's cool. I've got another question in incubation. Dr. Rack, did you have anything to add?
Oh, no, I was just going to reiterate that similar to we have a My Humber patient portal where they can see the results.
Excellent. The next question, then I'll go back to Madeline, is, as you can guess, I'm not a full-fledged Canadian. This is my best Canadian accent. So for an immigrant or an immigrant family with sickle cell, just arriving, first winter, second winter, struggling with so many variables, what can we do, or what do you do to sort of support these people? Or what can we recommend?
Yeah, so I mean, there could potentially be lots of layers there depending on the family's circumstances. One is just the settlement process and what their circumstances are, whether this was a planned move or not, and what their supports may be in the community. So I mean, you kind of honed right in on the winter, which is a big difference in terms of our climate compared to a lot of the rest of the world. And that can be a shock to the system, and particularly when it's layered on top of all of these other new things, some of which may be unpleasant surprises, like as you know, if they've left family supports behind, for example. So I think we again approach it very holistically. When I have a new patient, especially one who is new to the area, coming to the clinic, I set aside a large amount of time for visiting with them. This is not something that can be rushed. We're establishing a relationship. I'm getting to know them, they're getting to know me. And I shouldn't center myself because we have our whole multidisciplinary team. Each member of the team will meet with that family and take a look at various aspects of their life and how we can help to support them, including those issues of, you know, whether they have an OHIP card and drug access navigation, right down to education about the weather, you know, and how to dress for the weather. So, you know, sometimes it is that very practical discussion that a member of our team can have and making sure that the folks are ready for that. And less so in our adult setting, but I notice a lot with our clinic at McMaster Children's Hospital, as the team this morning had presented, is pediatric and adults, where I look after them 18 and up, and Dr. Uma Thale and the rest of our team look after them before that age. In children, it also involves helping to educate the parents and providing educational resources to send back to the school about things like cold weather days. And, you know, as much as we want our children who are living with sickle cell to have that activity of recess, there may be certain temperature days where it might be better for them to stay inside and making those decisions together with the family and educators. That's it in a brief nutshell. But ultimately, it comes back to assessing each individual person and family's unique needs and circumstances and trying to tailor what we do to them. I see our good friend, Ms. Lanre Tunji Ajayi, with her camera on and her hand up. So please join in, Lanre.
Thank you. I love to join the conversation. It's very interesting. And I totally agree with Madeline. When there are new immigrants, I mean, in addition to setting time, a good time apart to ensure that, you know, you give them the good counseling and the and the care that they do need, helping them to also know the resources in the community is very important. And this is taking me back to the question that Ayorinde asked before this one, certainly, you know, about the patient advisory councils in the various hospitals. And this is one of the reasons why we set up the PAC. Nothing about us without us. Right, so you have the patient voice to sit on those committees to provide their perspective, their insight into sickle cell programs, sickle cell guidelines, and sickle cell care. So SCEGO has the Patient Advisory and Advocacy Council, and I think everybody has heard today a few of those members who has been very active with some of the hospitals. So if you, I mean, it's not even about a view. If your hospital does not have sickle cell patient or a caregiver on your council, is something that you need to, you know, to really talk to us about. We will, you know, again, it's not, if we're not there, it's not about us. So for us to be part of that conversation, we need to be at the table, and we'll really be grateful for the opportunity to contribute and support the good work that you're doing. Thank you.
Thank you. And I believe we have until 2:45, but we may need a few minutes to leave a few minutes at the end for wrap up. I actually had a question back for you, Dr. Ayorinde. I was hoping that you might start us off. I'm looking at your comment that you had put in, the intersection of physical health, race, emotional, and mental health, PREM as an acronym. Each needs a carefully thought through strategy. I feel as though we've addressed the physical health, we've talked about the emotional and mental health. Where does racism, the experience of being Black or racialized in a historically white healthcare system, where does this come into all of it?
Well, thanks so much. And I made up the acronym on the spot. I thought of Mr. P. I thought, what would be cool? It's a tricky one, and race is one of those complex ones, the elephant in the room. Now, not everyone with sickle cell is visible with the disease and what they're dealing with. We know a large number are, and we're in a situation where we're dealing with very complex racialized experiences in use of health services, in school, in with stereotypes as well, and really how we support people who already feel different because of the sickle cell, who are living with occasionally bumpy education and work lives, and at times also deal with racism. I've got physician colleagues with sickle cell who've turned up now, to be fair, this was in the UK, but turned up in Emerge in a crisis and been told they were drug seeking. And one was told that as a hematologist with sickle cell. He was informed of all things he would want to do on a Saturday night, hook up in Emerge, looking for opioids. So I think we can do a lot more. And part of the strategy in some of this space would be with the representation, having advisories, people that can authenticate or endorse the great work being done. We've heard amazing work being done, but it just adds a little bit more to have the visible presence. Great work done with the slides. Many of the presentations had slides that did have representation, but there's a lot more to be done. I must say, as a physician of color, and ever since 2018, I've worn my SCOGO wristband. And I'm sure Ms. Lanre will ensure everyone gets it. But the sickle cell awareness wristband, I've worn this, oh, all right, it rocks. If you don't have one, you're not cool. But it's amazing when you're in clinic wearing that wristband. And I've had someone with schizophrenia ask me what it was about. And I said what it was. I said, oh, I went to school with someone with sickle cell, but I was just too worried to ask him. So what is it? Or you're in immigration and someone's asking you. So we have every opportunity. And I would actually call on Black physicians of Canada, Black physicians of Ontario, not because you guys aren't doing great work, but mobilizing knowledge whereby people of color who have the relevant lived experience or medical knowledge can support in important allyship here. Thank you.
Maybe Rob, you can speak to some of the work that our colleague, Dr. Urabina Simpson has been doing in Ottawa in that regard.
Well, I can't talk to what she's doing. She's doing amazing stuff, but I'll let her speak for herself. She's doing great work. The one thing I did want to comment on, and because now that I have my emergency colleagues here, because I know it's really challenging, the messaging, there's been so much messaging about how bad opioids is. And I've tried on many occasions to these groups that are, putting out guidelines on opioids to say, look, that is the treatment of choice. There's no great alternative to opioids for treating sickle cell disease. And I kind of, I think we're kind of pushed aside because we're a rare disease. And I understand they can't deal with every, nuance, but I do think that that's really, it's really been damaging to our patients and the war on opioids, I'll put it that way. So I'd like to hear how you guys, I think Dr. Eric, you were talking that there's a lot of concern or around giving opioids. We can talk about that.
Yeah, I think there's a lot of concern, specifically the pediatric population. So as a non-pediatric hospital, there's concern just simply because it's not a typical thing we do. So there needs to be a lot of education and handholding around that. But slowly, as we've introduced intranasal fentanyl and with an intranasal fentanyl order set and then education of nursing with that, I think there's more acceptance of that as a modality. What typically happens when you order an opiate for someone in a non-monitor setting, it becomes a big kerfuffle to move them to a monitor and watch them, and oh my gosh. But this is in the pediatric world. In the adult world, it's simply culture and stigma. I mean, giving pain medication to a cancer patient who's coming in a pain crisis, there's a lot of sympathy there. There's no question about drug seeking or not drug seeking. Opiate medication is standard of care for our cancer patients. And you sort of mentioned that this is a rare disease, but not so in our community. But I think that knowledge translation of treating it similarly like we do with cancer patients, that this is standard of care. This is the management they need, and this isn't simply somebody coming in with their chronic back pain for the fourth time in one day who lost their prescription. I mean, these are completely two different patients. It's unfortunate that it gets categorized within the same group, but certainly I think it's a culture change, and it's a reorientation that, just like with a cancer patient who has a chronic terminal disease, in this case, this is a chronic disease that this is the primary treatment for. So it's culture, and it's ongoing at bedside discussions with the nurses and the physicians.
Great. Well, thank you very much. I think we've got close to 120 seconds left, so I'm going to try to be quick. And on behalf of everyone who's attended, we'd like to thank our colleagues from St. Joe's, from Humber River Hospital, and from CHIO for the really, really engaging presentations and conversations. There's so many examples of best practice, and what we're hearing is great work being done, opportunity to do more. There's scope for innovation. Perhaps someone's going to come up with an app that just goes beep and reminds you it's cold outside, so dress differently, and so on. And I think what I'm hearing from all of you as well, and my co-host Madeline is saying, is there's never enough advocacy. And I believe I'm speaking on behalf of Ms. Lanre, saying we need more and more ambassadors from every single work of life. So thank you ever so much for the session. There's been a lot of learning, lots more to do, advocacy. And if you've got a red blood cell in you, join the action. Thank you. Final words from
Yes,
Mr. Lanre?
definitely. And Dr. Ayorinde, I love that. If you've got red blood in you, join the action. So today, you agree with me, today has been an impactful day. We've learned so much, and thank you again, Dr. Ayorinde, for bringing the mental health into the whole mix. I love that. That it's amazing. I want to thank everyone that joined us today. And I think for you to be with us from morning to this time, clearly demonstrates your commitment to sickle cell disease care improvement. And so we congratulate you for being a part of the equitable care for sickle cell disease care movement. And I'm going to add what Dr. Ayorinde said again. If you got the red blood cell in you, join the action, right? That's what you said, join the action. And thank you for the wristband reminder. And so we have those wristbands, if you would like some to distribute to your staff members and so on, we'll be happy to share those with you. Just send me a quick email or text and we will ship some to you. So again, I would say that we've all heard from individuals and caregivers with lived sickle cell experience on the current care that they do receive and the preferred care that they would like. You also agree with me that the hospitals represented here today are working very hard to improve the quality of care that they are providing to sickle cell disease patients. And for this, we're very grateful. We really thank our presenting hospitals who they're working very hard and helping to ensure that Ontario has a more standardized care. And that really would ensure that no matter which hospital our patients go to in the province, they will get good quality care. And this is very encouraging. We would also like to thank the Ministry of Health representatives who stayed with us all through the day. You graciously working with our community. We are very grateful. Furthermore, our industry partners, your innovative research will be the reason for a cure. And we thank you for all you're doing. Let's focus on this together. I'd like to thank our study team, Dr. Vaso-Occlusive, Dr. Kirby Allen, Dr. Williams, Soji, Mami, Sanjeev, and of course, my co-chair, Dr. Jennifer Bryan. Without this study, today's session will be impossible. I would also like to thank our moderators for today, You can tell they did an amazing job. Dr. Vehosek, Dr. Ayorinde, Dr. Jennifer Bryan, thank you so much. Finally, the peers with sickle cell disease. You go through immeasurable pain and you deal with it gallantly every time. You are our heroes. And together with your family members and we as community advocates, your care providers, working alongside you, we will bring the right care to you at the right time in Ontario.